been a while. This is my last lecture with you. I see you once in Capstone, but some of the things we're doing in Capstone are more skill-oriented. Not that we have a lecture per se, some review of information, but in terms of formal lecture, this is it. So, a couple things. One is that some of you may have wondered, some of you probably have forgotten, those prescriptions you have turned in. What I'm going to do is I'm bringing them in Capstone. We're going to have, I think there's a 2 hour or something allotted to prescriptions. I'm going to go over those. I'll hand them out and we'll look at where you're having trouble. There will be about 20 questions on the Capstone exam over prescriptions. I will hit the law hard. You've got to know your law. The other would be just then basics, abbreviations, things like that. I don't have it, I'll be able to tell you more then, but I'll probably have prescriptions that you will have to create in the exam. So that's just kind of a preview. Let's see. Anything else? Anything you were expecting from me and I haven't done? Any questions people have sent to me that I haven't answered? I've been pretty much out of the scene, so I'm sure you're not thinking far. Okay. Anything else? All right. I wasn't quite sure, and I looked at the schedule, couldn't find it, but is this the only thing you're having on COPD and asthma exacerbations? Did they cover it at all in any of the ER or anything there?
No.
Okay, that's fine then. I didn't see it, but I wasn't sure. Well, what blood was covering. Okay, so let's just think about asthma. Tell me what you remember about asthma. What are the cardinal symptoms? Wheezing. Okay, what else? Shortness of breath. Pardon? Chest tightness. Okay. All right. Basic pathophysiology. What's going on in the lungs?
Bronchoconstriction.
Okay, bronchoconstriction. Inflammation. That's the big thing. So we go after our main goals then with asthma is what?
Bronchodilation.
Bronchodilation.
Decrease in inflammation.
Decrease in inflammation. That usually will keep airways more open, people less likely to have exacerbation. Okay, so tell me some of the parameters we use to look at and evaluate the severity of an asthma disease.
Nighttime symptoms.
Yeah,
And take blood.
Okay, so nighttime I'm here. What else?
number of times they use their albuterol.
Okay, so number of times they are using their short-acting bronchodilator. Usually that's albuterol. What else?
Exacerbations.
Number of exacerbations. This is really important, and we're going to talk a lot about these today. I'm telling you, the closer you get to a blackboard, the worse you spell. It's true. Exacerbations. I know that's still not right. Okay, what else? That we go with here. Hospitalizations, ER visits. You should always ask about that. Okay, impact on activities of daily living.
Something caused it.
What?
If something caused it specifically.
Oh, triggers.
Like exercise.
We'll put those over in secondary triggers. Another really important thing you have to address. We'll talk about these that come into play today as well. What else?
Are they using it right?
Okay, that goes to, that would be one thing to evaluate if they're using a lot of short-acting bronchodilator. What else?
Peak flow.
Got peak flow. What's the goal for peak flow? I say that, what does that mean? What is peak flow measuring?
Lung capacity.
No, not capacity.
How much you can blow out in a breathing.
Expiratory volume?
Okay, the rate at which you can expire. Okay, so most of you, if you don't have asthma, you can get rid of almost all your volume, your forced expiratory volume in 1 minute, 1 second. Okay, and almost all of it in 3 seconds. Okay, people with asthma cannot do that. Why is that? Where's the disease? Bronchioles. Okay. So theirs is reduced. So peak expiratory flow rate mostly correlates with FEV1. Okay. When it's measured in liters per minute. We're going to talk about this today as well. Okay, let's see if you got them all. So how often they're symptomatic is one thing that should be up there. Nighttime. Okay. The other thing would be, another way you can look at exacerbations is the amount of, if they've had an exacerbation that required steroids, usually oral or IV. Okay? All right, so let's go back and look at these some more. Let's do this, just, whoops. We're going to look at this, about half of this for you too. This is just a review. You've got most of it. Just get your brain back in thinking. Sound. Remind me. Why don't I have sound?
Voice alright.
Don't tell me that before.
In the thorax region, the rib cage and a dome-shaped fibrous tissue, known as the diaphragm, are observed. In humans,
I know you
the
know
main
this.
organs
Just get it back in
responsible
your
for
brain.
respiration are present in the thoracic cavity. In the thorax region, the rib cage and a dome-shaped fibrous tissue, known as the diaphragm, are observed. Present within the rib cage are the pleural membranes, which enclose the lungs. The right lung is divided into 3 lobes: the right superior, right middle, and the right inferior lobe. The left lung is smaller and has only 2 lobes, the left superior and the left inferior lobe. Both the lungs are associated externally with small tubular bronchi, which unite and extend into the trachea. The trachea has incomplete C-shaped rings of cartilage, which prevent the tracheal wall from collapsing. The trachea leads into the pharynx, which is connected to the nostrils. As we breathe in air, the oxygen molecules enter the nostrils and travel downwards through the pharynx and trachea to finally reach the bronchi. From each bronchus, oxygen travels into the lungs. Within the lungs, the bronchus divides repeatedly to form bronchioles. Oxygen travels through these bronchioles and reaches the alveoli, each of which is surrounded by a network of capillaries. A section of one alveolus shows the presence of numerous alveolar chambers with pores. Blood containing RBCs is seen flowing through the capillaries. The oxygen molecules from the alveolus diffuse into the capillary and then get absorbed by the bluish-purple RBCs. This causes oxygenation of the RBCs, and a transition in their color from bluish-purple to red is observed. The blood moving into the alveolus contains RBCs and carbon dioxide molecules. These molecules are released into the alveolus. The carbon dioxide collects in the alveolar chamber. And then from the alveolus, it travels through the bronchioles into the bronchus, which finally reaches the trachea and is breathed out through the nostrils. So the process of breathing in air rich in oxygen is called inhalation. After the contraction of the muscular diaphragm, the lungs expand and the air rushes in, resulting in the inflation of the alveoli. During exhalation, the diaphragm moves up and the lungs contract. Thus, the alveoli deflate, causing the air to be forced out. This exhaled air is rich in carbon dioxide. This process of inhalation and exhalation is known as respiration, which is approximately 20 times per minute. Summary. In the thorax region, the rib cage and the diaphragm.
Okay, so now you got it in your brain. So here's what happens in an asthmatic. So it's important to remember the bronchioles, because in the bronchioles, you're the final tubes right before you get to the alveoli. So the big problem is when you clog those up, what can't you do anymore in that area? You cannot exchange gases. So that's why they get CO2 builds up, oxygenation goes down, and all the symptoms that go with it. This is another, I liked this picture. It brought a lot of things together. You can go back and look at it, but they show you air in and out, and they emphasize that bronchiole, where, can you see that? Mm-hmm. Bronchiole, and then what you're seeing in terms of an obstructive airway and a normal airway. This I like because it shows you what happens to those alveoli. So you got normal airway, everything looks good. You get an inflamed airway, you get a smaller diameter, you got higher resistance, so it takes a lot more time or pressure to go through that, and then you see where you just almost got a alveoli or a bronchiole that has extremely limited airflow. And look at what happens, you get air trapping in there. So what does it look like when you look at a X-ray? What's it going to look like? How do X-rays go through, what do X-rays look like when they go through air?
Black.
Black. So you see, unless they've got pneumonia, and I'll show you an X-ray here in a minute, one is it's hyperinflated, okay, because you've got a lot of air trapping, and that diaphragm is depressed, and you get a lot of just black. So we'll look at that. Unless, again, they have pneumonia. Or atelectasis, where those alveoli then collapse. Okay. So let's pick it up on page 2. So we're going to look at emergency care. We're going to look at what you would do in ER and hospital. We're also going to look at what you can do at home. What you do at home will be probably more dependent on you as a primary care provider, okay? And we're going to talk about those action plans. Those asthma action plans are really important. I've given you a copy of them. There's a lot of different groups that put these out. You can download them on the internet. You can order them, get tear off pages to give to the patient. So there's lots of different groups that do that. If you Google asthma action plans, you'll find a lot. American Lung Association, they used to give away free, I think they still do. So if you're going to deal with asthmatic patients, you need to have access to these. Every patient you see should have an action plan. Okay? So we're going to talk about how they're used for a home, management of a home exacerbation, usually a mild one. And then we're going to talk about your role in the ER is when you're discharging the person, you need to make sure they have an asthma plan. Now, for you to construct that probably isn't going to be time, there probably won't be time, and you probably won't know enough about the patient to do it all. But you can, there's elements of that you can go over with them and make sure that when they go back to their primary care provider, which should be pretty soon after they've been in hospitalized or ER, that they are aware that they should have a plan at home. Okay? All right. So let's look at, these are basic principles at the top. One is it's really important to assess the severity of the attack. That may be a duh, but often people will come in and they will look one way and they go south very quickly. Often patients who are unstable, have poorly controlled airways, have a diminished perception of how bad their airway disease is. Those folks tend to get in trouble very quickly and come in and die on you in the emergency room or in the hospital. Or you have to intubate them very quickly. So assessing the severity is important. Potential triggers. This is important because these often are the things that have set them off. Okay? Even people who have mild disease, mild asthma, can have life-threatening asthma exacerbations. Especially if they come into contact with a trigger and they didn't anticipate it. Let's say they, it's a kid and they go over to their friend's house and they have cats or dogs and nobody thought about that. Usually the mom has thought, the parents have thought about that. But they may get into a situation where they didn't anticipate it. Or they get into a car and somebody's taking them home and they smoke. Something like that. A lot of times it's chemicals. What did they use to clean the bathroom? Child goes into the bathroom, strong odors can set it off. Perfumes. They go into some place where people aren't really aware. I told you when we talked about asthma, I used to wear perfume up until the time I took care or was in a clinic. And then you could just tell. My clerk had asthma, and any strong or patients coming up to the window would just set her off into an asthma attack. So I really don't use anything anymore that's perfumed. Cold air. So this is a big time of the year where people start to have problems when they go outside. Fungus, spores, if they live in, let's say, Section 8 housing, or they live in a rented home or apartment where somebody's not taking good care of the property, if that fungus or mold builds up, it will set them off. A leak, a water burst, pipes bursting in an apartment, same thing. I've seen it multiple times in kids. Pollution. Your inner city folks are your most at risk because usually their quality of air, quality of living circumstances is most poor. So being aware of that. Stress. If you have children that are in very stressful homes or adults as well, that can set them off. They also will use it to manipulate. So once they figure out that an emotional response can lead to attention or care that they're not getting, they often will use it. So I'm always watching for it in children, especially if they're frequent returners to an emergency room or hospital, is what is going on at home. Always think about that, especially with kids. Or adults, I shouldn't downplay that. Pollen, so when you know there are high alerts, so if you're working in an emergency setting, or if you're primary care, paying attention to what they show you every day on the news about pollen count, mold count, sometimes will help. Exercise. So these are all important because in an exacerbation, one of the biggest thing is removing them from the trigger. If you keep exposing them to the trigger, they will continue to have an exacerbation. So getting them out of that is important. So that would play a big role in home management. Is when they do have an exacerbation, is to help them to think, is if I come into contact with something that is setting me off. So in that case, get away from it. Okay. So one of our mainstays is going to be short-acting bronchodilators, and it's going to be the beta agonist. Okay? Why a beta agonist over a muscarinic? Why is that? What's the difference in them? They both bronchodilate, but what's the one key difference?
Location.
Not location, it's onset. So the beta agonists, very quick. The muscarinics, they're an hour. They're very good, but they're too long. Glucocorticoids, these are mainstays. Another mainstay is whether you up the dose of the inhaled. So in home management, we can do that. And we'll get to this, I'm just giving previews. So in home management, we can up the dose of their inhaled corticosteroid. We can write that on their action plan. We can give them oral. We can give them IV. So the really, really important to keep that in mind and start early because it's delayed. Their effects delayed 6 to 12 hours. Making frequent objective assessments. So these people, if they're in your ER, you're having to look at them in the first hour, you're going to look at them about every 20 minutes. But then it's frequent observations. Sometimes these people take nosedives after you've observed them, even an hour or two, they can still go down. People who don't respond well after 4 to 6 hours of those are usually those that are admitted. The big thing is when you're discharging them is education. The one time that is most fruitful for educating patients is right at discharge or right after they go home. So the people I found I could have the most impact on are those that I saw within the first week after a hospitalization. They're usually heightened awareness. The longer they go, the more they don't show up to visits. And they don't really take what you're saying to heart. Okay, so those are the big principles. We're going to talk about each of those in detail. All right, initial assessment. So the one thing you want to know when they first come in is, what's your history? Here are some big things. You want to identify people who are at high risk for mortality. Because people who come in with some of these that we're going to talk about, their risk of dying in the next year, I'm not even talking about while you got them in the hospital, I'm talking in the next year, is 10% above. So it's really important to identify people at high risk. And when I'm in the outpatient, I'm always looking for that. What's your risk? Have they ever been intubated? High risk. ICU or mechanical intervention, these are the highest risk people. In the next 18 months, they are at greater risk of dying. Have they been admitted to the hospital in the past year for an asthma exacerbation? Have they had to go to the ER for treatments? This says 3 or more. So when I am seeing them outpatient, let's say I'm seeing them back, and I haven't seen them for a month. These are the things I ask them. You've been hospitalized since I last saw you for asthma. Have you gone to the emergency room for asthma? Have you gone to your doctor's office? So those are kind of my tiers. Hospitalization, most critical. You went to the ER, okay, not as bad, but still you could not manage it at home. And the next is you have to go into the doctor for a visit for a breathing treatment, okay? Not as bad, but it tells me that whatever we're doing at home is not working, or you're not doing what we asked you to do. Okay. Recent symptoms and triggers. Usually people, even and those at highest risk, probably the longest, people before they have an asthma exacerbation usually have had days to weeks of declining airway control. That's why those peak expiratory flow meters are really important. It's just, you cannot get people to do it. The more exacerbations they have, the more I drill on. If you will do this, you can tell at least 72 hours ahead of time their peak expiratory flow rate will start to decline until they hit a critical point where then all their symptoms become more urgent. Some people, it will be over a 2-week period or a several-week period where they'll just see marginal declines constant. Okay? So that is really important. A recent illness, I always look for viral. Have you had a viral illness? So this is the time of the year. Kids go back to school, they give each other their bugs, and you see asthma uptick when kids start going back to school. Recent exposure to a trigger. That would be another. But those pneumonias, viral illnesses, really important. Are they monitoring their peak expiratory flow rate? If they are, what are you seeing? Do they know their personal best? Do they know what their goal is? That's always a good sign. When I got people who can tell me that, and then they can tell me, well, I keep seeing this going down. It's not staying there. One is to check technique, because sometimes, and that will impact it as well. Asthma medication and adherence. I can tell you, number one, non-adherence is with the steroids. They'll take that albuterol because there's a quick response. So they know if I take my albuterol, I can breathe better. So one thing you want to look for is overuse. Okay. So the way you can figure that out is how many canisters are you going through? Okay. A canister has how many inhalations in it? 200. Okay. So and our goal for albuterol use is what's our goal?
1 time a week?
1 time a week, less than 2 times a week. So you can kind of average if it's so a bit over a month, you could look at it that way. Okay. So we want to know that, then you can figure out, because what's the dose when we give it to them? 1 to 2 puffs every 4 to 6 hours. So you can see that a canister should last them a long time, right? Okay. So more than 1 canister, I am very concerned. If you are using more than 2, that is dire. Something's wrong. Either you don't know how to use it or you are way in overuse. Okay. So you can always have a patient show you. Probably the ER is not the time to do that, but some follow-up needs to be done to ensure that they know how to use it. I'd also ask them, do you use it with a spacer device? If they're using a spacer device, they're more likely getting the drug down. Or are they using a nebulizer? That could be another. Have they quit? A lot of people quit. Steroids, lots of times I would find they quit because they can't tell it is doing anything. They don't get that immediate feedback unless you're teaching them and showing them, okay, as you've been on this steroid inhaler, look, you're doing better here and you're using less albuterol. So you have to keep making that connection. I have found with teenage boys, they are the least likely to use them because they think it affects their muscle strength. So, so that is always a kind of so the way I buy it is that you can stay on the court longer, you can stay out in the field longer, you can run longer, you can be in the game longer if you use your steroids. And the muscle part, I leave to the strengthening coach. But it far outweighs that benefit versus the muscle weakness that they feel like is causing them. The other is that they quit because of cost. These things are insanely expensive. So making sure they have the ability to get medications. With kids, it should not be so much a problem. Adults, it probably will be because of out-of-pocket costs. So a recent illness again, virus most common. Those airways stay hypersensitive for how long after a viral illness?
2 weeks.
2 to 8 weeks. You all hack all the time. So when you've had even if you don't have asthma, your airways will stay sensitive after you've had like an upper respiratory illness that has moved into your lungs. Don't you find that? You may cough for a long time. That's what that is. And in asthma, it is exaggerated. The other would be is to look for extreme allergic reactions. So if they have like a peanut allergy, those can certainly set off not only a reaction, but can then make them hypersensitive for a period of time. Okay. Ringing familiar? Okay, great. So initial assessment of acute asthma. This is really good, what they have done here. So looking at moderate, severe, life-threatening, look at the things they evaluate. They're fairly practical. Can the person talk to you? If you don't have enough breath, you can't talk. You can't tell in full sentences, you get easily fatigued, unable to talk. Pay attention to this because I'm going to show you a video here in a minute from the ER of a person who comes in with an asthma attack, and you'll see these things. And they have a severe to life-threatening. Are they alert or agitated? If you can't breathe, you are more anxious. The agitation goes up. But look over with life-threatening. Mental status changes should really prompt a consideration of intubating somebody because they certainly can't maintain an oxygenation. Look at their respiratory rate. So they start moving air more quickly because they can't oxygenate. Their PO2 is falling, their CO2. So the main driver here is that CO2 level, right? So the higher your CO2 level goes, the higher your respiration goes. So you can see from that very first video that I showed is their gas exchange is now all thrown off. May or may not use accessory muscles. So looking for those intercostal retractions, the use of their neck muscles, also their positioning. So they may tripod, so what do? Michelle, after you run really hard, what's your stance? You walk out fully upright?
That's right.
Okay, she's not an example. Have you ever run really hard and what is the first thing you see people do? They do this, right? Tripod. Your patients in the ER will do the same thing. So look at their position when you get in there. They will not lie down. They can't breathe. So they will lean forward and they will, because it tends to help the diaphragm work better and it helps those accessory muscles work better. Heart rate. So heart rate's going to go up. Why does heart rate go up?
Trying to oxygenate.
Oxygenation. So if you can't get enough oxygen on the red blood cells and you can't release them into the peripheral tissue, the heart will just start taking it around faster and faster. The other is that they're anxious and they're agitated. So sympathetic system outflow goes up as well. Oxygen saturation. So you're going to put a little oximeter on them and you're going to look to see what they're doing on room air. So our goal is about 92% above. We're also, for pregnant women, we'll go a little bit higher with 95%. Usually don't take them up to 100% if we put them on oxygen because it knocks out their respiratory drive. The other is their peak flow rate. So sometimes, and when you see this guy, you're like, you don't even have to ask him. So some of these things people won't do because they can tell by looking at the person that they are in such respiratory difficulty. Usually peak expiratory flow rates below 200, they're going to be hypercapnic. They just can't move enough air volume to keep up with getting rid of carbon dioxide and oxygenating. So for you all, most of you are in the range of 400 to 600. The guys are going to be in the 600, 700 range. Women are going to be in the 400 to 500 range. So you can see you're quite a bit. You're about 50%. So a 50% reduction in peak expiratory flow rate usually is indicative. If you're into the 25 to 40, if persons even can do it, those are people who are probably going to have to be intubated. All right. So we're going to go through this physical exam, then we're going to look at these videos. So what is patient awake and alert? So what's their mental status? And what is their fatigue? Watch this video with this guy. He is wearing out as he goes on. Tachypnic, so their respiratory rate is up, tachycardia, use of accessory muscles we talked about. When you listen to their lungs, they should be moving air in and out, right? In the areas where they are most constricted or you got big mucus plugs, there will be silence. Not a good thing, right? Inability to speak full sentences or phrases. They can't lie down. They won't want to lie down. They're going to be sitting up and they're going to be leaning forward for the most part. They may have a pulsus paradoxus. Have you gone over that? You know what pulsus paradoxus is?
Isn't the BP so low you can't feel a pulse?
You get a big drop in systolic with inspiration. I've got a short little video I'll show you on that just a moment. Okay. The other is, I'll tell you, most of the time these people are going to present at night. And so remember, peak expiratory flow rate lowest in the nighttime. Thus, we ask about nighttime symptoms. Okay? So if they're going to have trouble, that's when they usually get into trouble. Most people feel better during the day. You're going to find this with a lot of exacerbations of a lot of illnesses. People come in at night. There's something about nighttime. I've gone all day. I still feel worse. Nighttime seems to bring some type of more impending doom, anxiety in folks. So most of the time, they are 10 times more likely to present at night than they are in the daytime. And that's certainly what I saw in the emergency room. Okay, let's look at these. There's that tripoding. Shows you an adult. This is not Michelle. This is me. I had to run like Michelle. You see this young man. You can see the use of those accessory muscles up near his neck, leaning forward. Same with this child. These are all examples of tripoding. Okay. This will be just a quick reminder for you.
Welcome to the Stanford 25 video on pulsus paradoxus. Pulsus paradoxus is defined as a systolic pressure drop greater than 10 with inspiration. Normally, during inspiration, the decrease in intrathoracic pressure will cause an increase in blood flow to the right side of the heart, leading to an increase in pressure transmitted to the right ventricular walls. Since more blood remains in the lungs during inspiration, a small drop in systolic blood pressure is expected. However, in tamponade, the increase in blood flow and pressure on the right ventricle during inspiration cannot be transmitted to the right ventricular wall, and is in turn transmitted to the ventricular septum. This in turn leads to a decrease in left ventricular filling, which causes a decrease in stroke volume and a much lower systolic blood pressure. To measure pulsus paradoxus, all you need is a stethoscope and a blood pressure cuff. To test for pulsus paradoxus, slowly look for the first Korsakoff sound that will appear, then disappear during inspiration. Next, slowly listen for when the first Korsakoff sound no longer disappears with inspiration. This clip was recorded from a patient at Stanford University with a pericardial effusion. Pulsus paradoxus can be a valuable clinical tool and has been shown to have a sensitivity of 98% and a specificity of 83% in predicting cardiovascular compromise. Along with tamponade, pulsus paradoxus can be seen in some patients with constrictive pericarditis, during asthma or COPD exacerbations, and less commonly in other clinical scenarios. Importantly, pulsus paradoxus may not be present despite a patient being in cardiac tamponade in certain situations such as aortic regurgitation and atrial septal defect. In addition to other findings such as an elevated jugular venous pressure, tachycardia, and shortness of breath, pulsus paradoxus can serve to be a valuable tool in the evaluation of a patient with suspected cardiac tamponade. This has been a Stanford 25 video on pulsus paradoxus. Thanks for watching.
I don't know if you ever look at their stuff, but I find it to be pretty good. They have a whole series of videos like that. Okay, now this one is a young man who has come into the emergency room in a severe asthma exacerbation.
I'm Dr. Olson. How you doing? Having trouble breathing? Just breathe this in, okay?
Ramon Farkas is a chronic asthmatic.
1 to 4 probably, right? That means he's got pretty bad obstructive disease. Have you ever been intubated before? How many times? 4 times? He has having a severe asthma attack, and he's had a history of asthma. He's been put on a ventilator several times before, so he has the potential to get really sick really quickly. And he's having trouble breathing right now. We're going to put him on a machine that's going to help him breathe and open up his lungs a little bit. Just hang in there. Focus on breathing. You ever been on the CPAP machine? We're going to put you on that now, okay? Is this one of your worst attacks that you've ever had, or you've had worse? You've had worse. All right, that's good, then. The worst thing for these guys is when they can't keep up with their own breathing, we have to put them on a ventilator. We have to sedate them, and what's called intubate them. We'll just put a tube down their throat to help them breathe, and they get a lot of other problems associated with that. Infections from the tube, they lose their ability to breathe on their own, they have to go to the ICU for several days, so it's much better if we can avoid doing that.
But Ramon can barely breathe. It's going to be a fight to keep him off the ventilator. But the chest x-ray shows Dr. Olson's suspicions were correct.
He's got a pneumonia. Gnarly looking pneumonia. And he's got cephalization too. It looks like he may have a little bit of component of failure. It looks like you have a pneumonia on the right side of your chest, okay, in addition to the asthma symptoms that you're having. Deep breath. Okay, good. He's sounding a lot better than when he came in. He looks a lot more comfortable than when he came in. So we're going to admit him to probably a monitor setting, probably telemetry or ICU, just to keep an eye on him overnight and make sure he continues to get better.
Okay, so look back at that list that I showed you. What did you see in him? Use of accessory muscles, what?
Unable to speak.
Unable to speak. Of course, they had a mask over him. What'd you say?
Same. Just
Same.
yeah.
Okay, what else? Look back at that.
His respiratory rate was probably and his heart rate was
Accessory muscles.
Accessory muscles, hard for him to talk. Do you see how he was using his whole body to breathe? So you need that diaphragm to be able to contract and pull down, and when it does that, those alveoli will inflate. He can't do that. He can't get enough diaphragmatic muscle in order to inflate them enough to get ventilation and perfusion to match up. So that's why he is working so hard. He's doing everything to lift that rib cage up, which will cause a negative pressure, and the lungs will inflate. He couldn't do that. What they did is they used more like a CPAP machine that you use at night at positive pressure. So that's one thing that can be tried before moving on to intubation. So what was their plan for him? Admit, and for what? To monitor, big time. So that probably for at least 24 hours. And if they can get him to that point, usually people don't go ahead and then relapse. Usually if you can get them past that point and they're improving, they usually will. But he had a reason. He had a pneumonia. Most of the time you won't get a chest x-ray unless they would be some incident or something that makes you think there's something going on in the lungs that's contributing. So what would those things be? What would make you get a chest x-ray?
The lung sounds.
Lung sounds, what else? Fever, okay. So fever, you're going to do a lab, so white blood cell count up. So things that would make you think there's an infectious process. An older person, you might think about failure being part of it. Okay. All right, very good. Talk about that peak expiratory flow rate. Just some reminders about them. Remember, this is what they look like. There's all different types that can be used. They all are going to be dependent on somebody being able to stand up and doing a maximum expiration. That's why I think in a lot of times people don't use them, is because when you see this guy, there's no way. And you already know clinically that they're in trouble. If you look at, sorry. So this is what peak expiratory flow rates look like for populations. So when you look at a table, and I gave you tables in the handout, these are for a population. You can see that for men and women, they max at about 35. So you all are still on the uptick, most of you. And then you get a steady decline with age, and you'll see that in these as well. So if you look on page, let's see, next page, page 4, you'll see that there are different tables for men and women, adults versus children. Children will have different tables. You'll see that, so they're gender dependent, they're also population averages, height and age. So would somebody give me their age and their height and we'll plot, we'll look at where you are?
5'3".
You're 5'3", so
27.
you're 27. Okay, so she's between 25 and 30 on the bottom, and she is 5'3", so she's between that 60 and 65. So if you look at the lowest would be 418 up to 448, so she's somewhere around that 430 mark, okay? So let's just age her about 40 years. Let's take her down to about 60, and you'll see 380 to 406. So you see a decline. It's not a big decline. Usually for most people it's about 5 to 10 mils per year. Smokers is about 10 times that rate. It's about 50 per year. So it's accelerated in people who are smokers. Now, population averages. So when we talk about personal best, we have someone in the office with maximal effort, do 3 of those peak expiratory flow rate. We then label whatever they can do as their personal best. Okay? Then the 80% is off their personal best. So when I talk about peak expiratory flow rates and I say personal best, that's the terminology you should use with them. It may not match the table. Okay? Especially in children, you'll see this. If they have lived with smokers, lived in a smoke-filled house, their lung maturation will be low. Some people are born with smaller lungs. Some people have other diseases that will cause a decrease in those. That's why we look at personal best. Then some of what I've got on there is repetitious. On the top of page 4, 50% baseline signifies a significant exacerbation, and we label that as the red zone. You fall below 50% of your peak expiratory flow rate, you are in great danger and you need medical attention. Then it shows you there on the 25 to 40, that's the need for usually some type of assistance to breathe. Let me see if I can get through the rest of this down to the bottom before I have to leave. Okay, you all are familiar with these. You do these in the clinic. You're used to how to measure a pulse ox. Okay, kind of gives you a picture and shows you what it looks like and what it's measuring. Okay, so oxygen saturation usually going to be poor. Marked hypoxemia is a big sign that they cannot maintain it. So that would be a partial pressure of oxygen less than 60 and a saturation less than 90. Hypercapnia. This one is important. So hypercapnia, normal is what? For CO2 in the blood?
40.
35 to 45. So above 45 is hypercapnic. So hypercapnia, usually if they've got a good enough flow, so this tells you a peak expiratory flow rate of 200 or greater, usually they're not going to be hypercapnic. If you did get a peak flow that was below that, then more than likely their CO2 levels are going to be up. They cannot ventilate enough to blow it off. Okay. So remember, respiratory rate, this is a good graph, and CO2 go in opposite directions. The faster you breathe, the more CO2 you can blow off. So you see here, you've got the partial pressure of CO2 in the arteries on the y-axis, and on the x-axis you have alveolar ventilation. So the better your ventilation, you're in the normal range. So this is a normal range, normal ventilation, normal CO2. But look, when you're getting down here in this low end, look at where it is. So when we're getting up to 45 to 60, you can see their ventilation is very low. Okay, so opposite directions. If you look at that bolded one, if they are normocapnic, but they are clinically appear to not be able to ventilate well, that is a bad sign. They can't blow it off. They can't move enough air to even get rid of, or to get rid of CO2. Then their brain is not responding. So the big driver of ventilation is the brain. So once you start having great deteriorations, then those labs, though normal, are in an abnormal or abnormally appearing. A lot of times, if y'all talked about arterial blood gases, okay, they are very hard to get. You have to be pretty skilled, and they are painful to the patient. So what some ERs are now doing is using venous. It's easy to get. A lot of people can obtain it on your staff, and it is not as painful to the patient. So just be aware that some are starting to use venous numbers instead of arterial numbers. Again, chest x-ray, not usually used unless you have a reason to suspect that there's something on that chest x-ray that's going to help you in terms of determining what is wrong with the person. So here is a chest x-ray. Tell me what you see. This is a woman with a severe asthma attack. Pardon?
Lots of air.
Okay, so it's hyperlucent. So it's hyperinflated. What about those diaphragm? They're flattened. Okay? Usually you don't see the very bottom part of the heart at all. Okay? And usually it has a more domed appearance. So flattened out, hyperinflated lungs. So this is what it would look like. Okay. All right. Let me dismiss you for now, and I'll be back at 10:30, and we'll pick up.